So if we could refocus, we are going to move from the broad introductory material we had this morning about all the basic principles now into organ-specific type of imaging so that you can hear how they apply for different types of applications. And so I would first like to welcome back my colleague, Dr. J.G. Fletcher, to talk about abdominal imaging.
Thanks, Cynthia. It's a pleasure to be with you. And, I think the food at this meeting is a lot better than it is at most radiologist meetings. I really appreciate that. So, as a gastrointestinal radiologist, that's important. So, disclosures. Okay, so I want to focus on three broad things. I want to talk about what is the good body CT exam. And I want to, we've kind of been focused on larger issues. I want to throw out some benchmark ideas that you can start to incorporate into your practice as you optimize for specific organs and diseases. I want to talk about superfluous imaging and some implementation issues for optimizing in your practice. And then I want to talk a plea to the AAPM about what we mean by diagnostic image quality. So the good exam is the exam that results in maximal benefit to the patient over their lifetime. And, you've seen these slides before. It needs to be justified medically. That is, balancing the benefits must be greater than the risks. And in terms of the treatment of the patient, must exceed the small risk of IV contrast and radiation. And an alternative way of stating benefit is that the risk of not performing the exam must exceed the risk of the examination. I like that quote. Now, this justification is also based on patient risk. For example, if you think a patient has colon cancer, it's very important to detect if they have hepatic metastases. That will determine whether or not they can survive and important treatment. If they're asymptomatic, the relative benefit, of course, is decreased. It has to do with appropriateness compared to other alternative imaging modalities and clinical assessment, and ameliorating factors, patient comorbidities and compliance. Can they be in a scanner for 30 minutes? If not, CT is more important. And local expertise and availability. And all of these factors really create a unique benefit and risk profile for each patient. Now, in terms of appropriateness, the ACR has done a wonderful job, as Jim highlighted earlier, with these ACR appropriateness criteria, which list the relative appropriateness of different types of exams. And then along with those is a relatively erudite summary of the literature and expert opinion. Now, in general, however, this is not linked to CT acquisition protocols, although often they will address superfluous imaging like extra series that may not be required. So, along with justification, the exam needs to be optimized. Of course, we're all familiar with ALARA using as doses as low as reasonably achievable without compromising the diagnostic task, and adapting the CT acquisition to the patient and the disease. But there's a lot of factors to consider along with the radiation dose, and I do want to focus on those, so as you work to optimize your protocols, you're thinking about them. The type and rate of IV contrast, the phase of enhancement, the type, amount, and timing of enteric contrast, alternative modalities, and patient-specific factors. So I'd like to focus on optimization in terms of maximizing the disease detection while minimizing the dose and the non-radiation risk. And I'll divide this into three broad categories. The CT acquisition parameters that affect what we see on the image, the spatial and temporal resolution, the contrast and noise, and timing or enhancement of the organs. The patient preparation, the oral and intravenous contrast delivery, and then the visual assessment of critical structures and relevant CT data. And that can be in the radiologist review of the images, but also in the image reconstruction and post-processing that we use to interrogate that CT data. So let's focus first on the CT acquisition parameters that affect what we see in the image. And for this, I think it's very useful to start out by thinking about the disease and the patient, And for patient preparation, it's actually easier to think about what you can control. But start out with the patient and the disease, and then think about the parameters under user control. And I'd like to focus on this first group. Think about the size of the index pathology. So in colonography, we're looking for a 6 millimeter polyp. Okay, so that means that we're going to want our slice thickness to be at 2 to 3 millimeters maximum to detect those polyps routinely. We want to think about the temporal importance of enhancement. Okay, there are certain phases of enhancement where the attenuation difference between an organ and the tumor that most frequently occurs in that organ occur. Okay, and for that we're going to need to think about the table speed. If we're doing a multiphasic exam where we have to scan through the organs in 10 seconds, we're going to have to think about issues of heat capacity, collimation, and scanner. We're going to think about contrast. Of course, in the liver, we're thinking about the timing of the contrast as it flows through the arteries, portal vein and hepatic parenchyma. In the gut, we're thinking of contrast as it flows through the bowel wall or within the lumen. So I'm going to start off by looking at some of those parameters and show you some clear examples of how they really affect the benefit to the patient as well as the acquisition. Now, I was called to look at this scan right after I joined the staff. This is a 6 millimeter slice CT scan, and it was read as negative in a patient with weight loss, and the gastroenterologist called me and asked me to look at it. And we noticed together that there was a small amount of, it looked like there might be a small amount of duct dilation. Brought the patient back the next day. Okay, this is a 4-slice scanner. This is nothing fancy. Okay, you can see the dilated common bile duct, the dilated pancreatic duct, and see the attenuation of this mass compared to the enhancing pancreatic parenchyma. Any radiologist would recognize this as a pancreatic adenocarcinoma. Okay, so this patient was able to undergo resection because I scanned with thinner slices and more dose. Okay, so this patient benefited from more dose and thinner slices. So just to give you a launch-off point, this will differ between institutions and radiologists. I'm just throwing out what we use. For survey or follow-up imaging in the abdomen and pelvis, we typically use a 5 millimeter image slice thickness. When you're looking at the liver, pancreas, and bowel, okay, the liver is a heterogeneous organ. The pancreas, we're looking at that thin pancreatic duct. In the bowel, we're looking at the bowel wall, which is 2 to 3 millimeters in slice. You're going to want to pick slices that are 3 millimeters or less. When we think about slice thickness and dose, talking about that noise compromise, which Jim talked about earlier, dose reduction is possible when with thin slices when a lot of contrast defines the lesion. So we're all familiar with colonography, okay, where you can easily do a colonography exam of the abdomen and pelvis with a CT-DI vol of 3 or 4 milligray. Okay, in interrography, where we're looking for that segmental hyperenhancement of the bowel loops, there's a lot of contrast. Or in patients with a renal stone, where we're looking at the contrast of a uric acid or a calcium stone compared to the adjacent soft tissue, we can really reduce the dose. And we implement this in our practice. So as an example, our low-dose stone protocol we use for patients with known stone disease and a prior CT. This is the overwhelming majority of the patients that we use it for, and we actually track that as a quality measure in our practice. And we also use it as a pre-contrast imaging for CT urography. So, of course, we're going to exclude patients that are very large, right, or have metal in their backs, but we drop the quality reference mass from 240 to 100 MA. So you can see that translates into a large dose reduction. And here's an example. This is the initial CT, which shows a 1 millimeter 2 millimeter calyceal tip stone in the lower pole of the right kidney. And then here's the follow-up exam just a couple of weeks later, and you can see the same stone. So dose reduction is not a good idea for subtle tumors in solid and complex organs. And here I'm talking about the pancreas, where we have some fatty marbling of the pancreatic parenchyma with the retroperitoneal fat, or the liver. So our dose settings are about 30% higher as we narrow our slice thicknesses in the liver and pancreas as opposed to our routine settings. So here's an example of a typical patient with cirrhosis, okay, and the lesion, you can see that nodular contour is this. So you can see that background noise. I'm not going to want to reduce the dose a lot, or I'm going to miss that lesion. Phase of enhancement. This refers to how the contrast flows through the organ. This really can make a big difference. This is a patient I showed you earlier, but I didn't show you their earlier outside CT scan. This is kind of a slow injection portal phase image. Okay, and it looked like the duct was abruptly cutting off here, although we don't appreciate any attenuation difference. Okay, look at this attenuation difference, probably almost 100 HU between this duct obstructing adenocarcinoma and the adjacent pancreatic parenchyma. This is in the pancreatic phase about 20 seconds earlier. So the phases of enhancement are designed to maximize organ and tumor detection. For early and late arterial imaging, we look at the arteries and tumor blush. For pancreatic and enteric imaging, we're really looking for maximal organ enhancement. And for delayed imaging, we're looking for tumor washout, that is, the tumor becoming hypoattenuating compared to the background gland. When do these occur? Just to kind of give you an idea, the early arterial phase we typically use for angiography or for very hypervascular pathologies, such as HHT, it's a hereditary telangiectasia, which are vascular lesions, or islet cell tumors. And these are usually in the 15 seconds, or they can be bolus triggered. Late arterial imaging, you can add seconds onto your bolus trigger. Those occur about 35 seconds later, and we use that for the most common liver tumor, hepatocellular carcinoma. Our pancreatic phase, you can see, occurs about 45 seconds after injection, and we use that for pancreatic tumors. For enteric phase, that's the point of maximal bowel enhancement, and we use that for Crohn's. That's about the same time as the pancreatic phase. The portal phase, of course, is our workhorse, where both the portal vein and hepatic veins are opacified within the liver. And that usually occurs 60 to 70 seconds after injection. And then delayed imaging we use for tumor washout, and that occurs minutes after the injection. So for the liver, we typically would use 3 phases, an early or late arterial phase depending on the suspected pathology, as well as a portal and delayed phase. For the pancreas, we use a pancreatic phase because this will help us to detect the tumors. The portal phase is used to help us stage the liver and look at the surrounding veins. We use both for the first-time tumor detection as well as pancreatitis, but we usually follow up patients with just a single phase. The kidney, there's a lot of phases. They're called by a lot of different things by a lot of people. People usually have strong preferences, so I kind of wanted to avoid that. But with the kidney, when you evaluate a renal mass, you're typically going to do an unenhanced series as well as the 2 or 3 other phases that they prefer. For bowel imaging, we typically do a single phase, but we do multi-phase imaging when we're worried about mesenteric ischemia, narrowing of the celiac or SMA artery, or we're looking for a cause of occult GI blood loss. And then the colon, we look for colonic enhancement. It's pretty forgiving. We can look in the portal or enteric phase. But I want to show you, this is a dramatic example of something we never used to see in CT. This is a patient with hereditary telangiectasia, and we didn't know that the livers were often involved with these patients, but this is the early arterial phase, and we can see these little asterisk-shaped telangiectasias in the liver, and we actually see shunting through these telangiectasias into an hepatic vein. You can see those small telangiectasias. So this is really important because a lot of these patients will die from high-output heart failure caused by hepatic involvement. So for our common tumor rule-outs, here's how we would typically image. For our liver rule-out HCC, we're going to use a higher dose exam. We're going to stick with the thin slices. We would do a late arterial phase image because that's where the tumor blush occurs in these patients in clinical studies. We'd do a portal phase, and then we'd do a delayed phase because about 10% of HCCs will show this tumor washout that we don't see earlier. And we'll get axial and coronal images. For pancreas, the most common tumor is pancreatic adenocarcinoma. We'll do something very similar, but we'll use the pancreatic and portal phase. Okay, what about the size of the patient? Well, we've heard a lot about this. I believe the technique should always be adapted to patient size, both to minimize the dose and to maximize the contrast. And I'm not just talking about iodine contrast, but also oral contrast and image quality. So for the smaller patients, you've heard about the AEC, the technique charts, and the KV selection, but also think about decreasing your IV contrast load as well as changing your oral contrast. For the morbidly obese patients, there are the problems with image quality. The other thing, though, is that with these multi-phase exams, you just cannot maintain the image quality as you scan through quickly. So you have other problems like heat capacity, field of view, and table limit things to think about. I find it very practical wherever I'm working in the clinic to think about where are my obese-friendly scanners that I can shuttle a patient to, okay? And those are the types of things I would consider. You've heard about some of the things you're going to do to slow your table speed so you can increase your tube current, choose a thicker detector width, increase your tube energy, employ dual source, or slow your rotation time. Patient preparation. Okay, this talks about some of the things that you may not be familiar with if you're a physicist in terms of oral and IV contrast delivery. But let me just show you two examples that we never saw when I just started on staff a couple of years ago. This is a patient with Peutz-Jeghers disease. The patient's undergoing a CT enteroclysis exam where we're injecting positive contrast through a nasojejunal tube. And look at the innumerable small polyps. These are all hamartomatous in the polyps in the small bowel. As they get larger, it's feared that there is dysplasia occurring in some of these polyps, so they're followed by imaging until the patients get to a certain size. And so this is really an exquisite technique. Because of that high contrast difference between the positive contrast and the soft tissue attenuation polyp, I can really reduce my tube current. Okay, so I can do this at a low dose technique. 7 years ago with capsule endoscopy, they said there was no role anymore for imaging in the small bowel for patients with occult GI blood loss. Jim Huprich at our institution just completed a prospective study comparing capsule endoscopy to multi-phase CT enterography exam and actually found that CT detects significantly more tumors than capsule endoscopy. So this is a patient with a small bowel angioma. So it really does matter. For patient preparation, there are fewer parameters to consider. So it's easier just to kind of click through them in your mind and say, well, which choice will benefit this particular patient? Okay, so for iodinated contrast, I'm going to think of the type, the injection rate and delivery. I'm going to think about what phases I want to look at. For the enteric contrast, I'm going to be thinking about what is my pathology. Is that going to be highlighted better by using a bright agent in the lumen or by enhancing the bowel wall and using a negative agent in the lumen? And then for colonography, of course, there's the bowel preparation. I'm going to want to be thinking, do I need to really distend the bowel to see the pathology? I'm not going to spend a lot on iodinated IV contrast. It's highly idiosyncratic from institution to institution, and people usually have strong feelings. But you should know that the concentration and rate of injection affect the phases of enhancement that you're looking at. So this is a table that we frequently use, and you can see that as your rate goes up, the contrast bolus shortens, and you need to image earlier to hit that pancreatic and portal phases. Okay? And there's various protocols, which I think some of the later speakers will address. So for oral contrast agents, you can think of the positive oral contrast agents. These are the ones that are bright and barium and iodine, and we typically use these for our screening exams or for cancer follow-up because we're looking for peritoneal implants on the outside of the small bowel. Or the neutral contrast agents like water, polyethylene glycol, or volumen, which is some low concentration barium with a sugar alcohol to prevent the water resorption. And we typically use these for CT angiograms or for small bowel evaluation. This is a graph showing different oral contrast agents, the diameter of the bowel over time, and the blue is water. So if you're giving water, you should know that it's going to be resorbed over the small bowel over time, so you're going to want to use probably another agent if you're looking at the ileum. Okay, because this is what we really want to see in Crohn's disease, for example. This segmental patchy hyperenhancement that you see in this terminal ileum is pathognomonic for Crohn's disease. So for the small bowel oral contrast agents, we want to talk about administration and timing. And for the positive contrast agents, we give about 2 bottles 20 minutes apart, and then you can image 20 minutes later. And then for the neutral agents, we give about twice that. Visual assessment of critical structures and relevant CT data. So we want to think about, will 2 planes increase the conspicuity? We're going to use automatic 2D multiplanar renderings. Is a 3-dimensional structure, is there a 3-dimensional structure with large contrast differences, like a vessel, something we want to see? We're going to do some 3D renderings. Will material classification assist in the diagnosis? And are the images too noisy? There are things that we can employ for all of those. So coronal images in pretty much every abdominal organ have been shown to increase the radiologist's confidence. And that's really important. Look at this little hyper-enhancing lesion on the axial image. Seeing it on the coronal image really increases your confidence. And this was a 7-millimeter carcinoid tumor that was able to be resected without any metastases. So it is really important. And the second thing is, don't give us any coronal images. If they're not going to be high quality, if we're not going to reconstruct them from thin axial slices, it's not worth it. So this is the type of problems that we're faced with every day. Here's a filling defect we can see in the jejunum. Here it is on the coronal. I feel very confident that turned out to be an ectopic pancreas. So, the slice thicknesses that we reconstruct our coronal images from, they really need to be 1 millimeter or less, or if you have to go to a thicker detector configuration, you can still keep that reconstruction interval under 1 millimeter. It'll look better. And of course, there's the image reconstruction and post-processing that can improve benefit. In this example of a villus adenoma at CT colonography and gout at dual energy CT. So the easiest way to minimize our dose is to eliminate the phases that don't contribute to diagnosis, and that's getting rid of the superfluous series. Okay, so the most egregious ones, I think, are the non-contrast exams in a multi-phase exam. It's usually not helpful unless you're looking for renal stones or it's the initial scan for pancreatitis where you're looking for a common bile duct stone. The other is the routine delayed imaging. If you're doing these in your practice, you're giving the patients excess radiation that's generally unhelpful, completely indicated when you have one of these pathologies that you might be looking for, but too often just done routinely. We talked about follow-up exams. You can save series and dose on those. We can lower the tube current with renal stone. We can decrease the number of phases. So you can see that in looking at all of these things, we really have an impact on the acquisition and visual assessment that both modifies the risk and the benefit to the patient because we're changing the CT exam so that it can become accurate for the pathologies. And this individualization really needs to be communicated to the allied health staff. And this is how we do it, a wonderful tool put together by Jim and Cynthia and our physics team at our institution. And you can see that for abdominal imaging, we have our routine exam and then our organ-specific exams. And that for any indication, there might be different scanners that can actually do that. And so it really impacts all aspects of your practice, including scheduling. So for our tri-phase interrographies, those can only be done on certain scanners, and so the patients have to be scheduled there. And then here are the acquisition protocols. So both the radiologist, technologist, nurse all have the same vision of what's going on, and it can be relayed in a single interrography, single-phase scoop. Individualization really requires planning by an integrated team, and it's a daily and ongoing commitment. In the last couple of minutes, I want to talk about what is diagnostic image quality, because we hear this term thrown out a lot. So, of course, Justice Potter Stewart was referring to pornography here, but this is how radiologists feel about I know it when I see it. So it's often graded on a 5-point scale. The definitions vary. People are trying to make it up. They're trying their best to say what it is with their definitions, and the reproducibility is often good or fair. And it's sometimes accompanied by subjective scales such as artifact scores, diagnostic confidence scores, conspicuity scores, noise and noise texture scores. Yeah, I've done all that. And objective measurements. You can measure the noise and contrast. You can measure the gradient sharpness across an image. The European guidelines on the quality CT criteria have been a little more specific and are a really useful step forward, where they talk about the visualization of critical structures. Did you get all of the liver? Visually sharp reproduction of small vessels, lymph nodes, and vascular organs. They also have some reference levels and some minimal slice thicknesses. They grade subjective noise, and this is kind of the three bears, where 1 is too little, 3 is too much, and 2 is just right. Well, that's kind of in the eye of the beholder, too. And then the diagnostic confidence score. So I think this is a great start, but there are weaknesses because it's too forgiving. The objective measures of sharpness, noise, texture, and low contrast conspicuity really need to be there so that we have an equivalent playing field between institutions. And we need standardized subjective measures of noise, texture, and conspicuity, probably from common image data sets. So I think similar AAPM guidelines would be a boon to the development, evaluation, and validation of noise reduction technologies in our practice. So I'm going to skip my example and move on to conclusions. So I think CT imaging really greatly benefits patients in practice, particularly as referring physicians realize the individualization of current CT scanners. There's the net benefit that's affected by the patient risk and the appropriateness of exam, as well as the optimization of the CT technique. The benefit is maximized by individual consideration. And we really need protocol development incorporating CT acquisition, patient preparation, and visualization, and a continuing commitment to this as scanners evolve and more clinical data emerges. Thanks.